right, thank you everyone for joining. Thank you for that introduction. So I'm excited to present this trial and interested in to see the discussion surrounding this trial looking at target temperature management for cardiac arrest with non-shockable rhythm. And hopefully Dr. Lascarrou will be joining us shortly. So this was originally published in December of 2019 in the New England Journal of Medicine. So a little bit of background. We know that in cardiac arrest patients who survive to ICU or CCU, the most common cause of morbidity mortality is actually related to their hypoxic ischemic brain injury. And that's particularly true for patients who have a non-shockable rhythm. And that has led investigators to be curious about the neuroprotective effects of hypothermia. And this was first investigated back in 2002 with the hypothermia after cardiac arrest study group. And what these investigators did is they looked at VF or pulseless VT and treated these patients to a target temperature of 32 to 34 degrees and looking at the primary outcomes, mainly on neurological outcomes. And what they found was a statistically significant difference in neurological outcomes in patients with hypothermia versus normothermia. More familiar is the 2013 target temperature management trial, which actually looked at two different temperatures, 33 versus 36. And this is an out-of-hospital cardiac arrest population. Approximately 20% of these patients had a non-shockable rhythm. The rest of the rhythms were in fact shockable. And what they found was that 33 versus 36 did not reduce all-cause mortality or improve neurological outcomes. A subset of this study actually looked at these patients with non-shockable rhythm and again proved the same, that there was no difference in mortality or neurological outcomes. And so Lascarrou and his colleagues, what they set to do was a randomized control trial looking specifically at non-shockable rhythms and asking whether or not target temperature management at 33 compared with normothermia at 37 improved 90-day neurological outcomes in unresponsive patients with successful resuscitation after cardiac arrest. And this was both in and out of hospital cardiac arrest. And the way this trial was designed was a multi-center, open-label, blinded outcome assessor randomized control trial, 25 ICUs in France, and this combined both academic and community ICUs, and enrolled patients over a 4-year period. And so in order to be eligible for this study, you had to be over the age of 18, have a Glasgow Coma scale of less than 8, so non-responsive, just like the other trials, and have a cardiac arrest with a non-shockable rhythm. They excluded patients with a no flow time of less than 10 minutes, low flow time of greater than 60 minutes, or major hemodynamic instability, which they described as 1 mic per kilo per minute of epi use during resuscitation, or time for screening to randomization of greater than 300 minutes. And so the group were allocated to target temperature at either 33 or 37, which I'll go into a little bit later, but their primary endpoint was actually a neurological endpoint, which looked at CPC scores of 1 to 2, which in the cerebral performance category scale, which are described normally as a favorable outcome. And the secondary endpoints although they evaluated a lot, the ones I'll focus on are ICU mortality, hospital mortality, and 90-day mortality. And so this is an actual depiction of the intervention arm and the control arm in this study. And in the hypothermia group, you can see here that they were cooled to 33 degrees, plus or minus 0.5 degrees Celsius for the first 24 hours. And then they had a rewarming phase of 0.25 to 0.5 degrees per hour until they reached normothermia, and that was maintained for another 24 hours. In the control arm, you can see that normothermia was targeted at 37 degrees with an allowance of plus or minus 0.5 degrees Celsius for 48 hours. So over 2,000 patients were assessed for eligibility and 584 were ultimately randomized, 284 in the hypothermia arm and 297 in the normothermia arm. Notably, 1 patient was lost to follow-up in the hypothermia arm and only 2 patients in the normothermia arm. And these patients were actually coded as dead in the analysis. And I should mention this was an intention to treat study. With regards to the baseline characteristics, so the average person was a 67-year-old male. 60% of these patients had chronic heart disease, and it was a sick population with 80% of these patients having an asystolic rhythm at presentation. Most of them arrested at home. That was about 50% of patients, and about 2/3 had bystander CPR. When we look at the actual cause of death, the most common cause in this patient population was actually asphyxia, which was about 60%. Cardiac cause was the most common, second most common at 30%. And overall cardiac causes of death in this trial accounted for approximately 1/3 of patients. And circulatory shock was present in about 56 to 60% of these patients. In terms of the modalities and timing of target temperature management, in the hypothermia arm, a majority of the patients had dedicated closed loop surface devices, while in the normal thermia arm, a majority of patients actually had basic external cooling. The time between randomization and induction of cooling in the hypothermia arm was 16 minutes, and time between randomization and goal temperature of 33 was actually 317 minutes. And so there's about 36 patients that needed to be rewarmed in the hypothermia group. And the majority of the reason for rewarming was actually related to hemodynamic stability, which accounted for 1/3 of the rewarming. I like this graph. It's the mean body temperature during the intervention period between the hypothermia and the normal thermia arm, with the bars indicating 2 standard deviations above the mean. I just want to bring your attention to the dark blue line, which is the normal thermia group, and the standard deviation. You can see that some patients there had temperatures above 38 degrees, while notably in the intervention time, hypothermia group did not. So overall, again, as mentioned, a very sick group of patients, 82% ultimately passed away during the 90-day period. 62% had withdrawal of life support as the major cause of death. The second most common cause of death was actually multi-organ failure, and the third was brain death. With regards to the primary endpoints in this trial, favorable CPC of 1 or 2 was achieved in 10% of the hypothermia group versus 5.7% in the normal thermia group, with a number needed to treat of 22, the p-value of less than 0.04. With regards to the other secondary outcomes, you can see there that 90-day mortality, ICU mortality, and survival to hospital discharge was not statistically significant between the two groups. And this ultimately led to the conclusion that in non-responsive patients with resuscitated, non-shockable, out-of-hospital or in-hospital cardiac arrest of cardiac and non-cardiac causes, the use of target temperature management at 33 degrees for 24 hours resulted in a higher percentage of patients with favorable neurological outcomes at 90 days, but no change in 90-day mortality. A little bit about the limitations within the study. So patients in the 33-degree group were actually subjected to longer duration of temperature control. If you recall the diagram I showed earlier, there was a period of rewarming of 0.25 degrees centigrade to 0.5 degrees centigrade. And that overall period resulted in about 56 to 64 hours of cooling in total, where the normal thermia group had exactly 48 hours of target temperature control. And so there is some thought that perhaps it's not the depth of cooling that's related to the neuroprotective effects, but the prevention of temperature and fever that may be protective in this population, and this may have affected the results. Furthermore, in the patients with a normothermia group, they had temperatures above 38 degrees, which I showed you earlier in the first 24 hours. And a lot of that may have actually been related to the precision of the temperature control in that group, which was basically mainly controlled by basic external cooling compared to the hypothermia group. And there were 25 ICUs, and credit to the author, that quite a bit of work going into this, but there was no standard way of standardizing the method of cooling and temperature measurement among the different sites. Notably, the fragility index in the study was 1. When you use a Fisher exact test, the p-value is actually less than 0.047, very close to 0.05, meaning that a change in outcome in one patient would actually make this a non-statistically significant trial. And some of that fragility index is probably also affected by the fact that if we knew the rhythm in 9% of these patients, maybe the results in this trial would have been a little bit different. There were also patients that were lost to follow-up that were coded as dead, albeit there were only 3 patients, but again, with a fragility index of 1, that may have affected the outcome of this trial. All right, I hope that Dr. Lascarrou is here so we can talk about some of the limitations that I've brought up, and I'd love to hear a little bit more from them.
Yeah, is Dr. Lascarrou here? I don't see your name. Hi, thank you so much for that presentation. I don't see Dr. Lascarrou's name here, but maybe he is. If he is here, just please speak up. Maybe I can start us off with the questions. There's a lot of interesting things that came out of the study. To me, can you put up the subgroup analysis? If you actually look at table 1 also, so 25%, about 25 to 30% of the patients were in hospital rest, and the rest were out of hospital rest. And if you look at the subgroup analysis, it actually favored hypothermia in the subgroup analysis, albeit with a smaller sample size, you get a larger confidence interval. But this is interesting to me, and I couldn't find even in the supplemental data kind of in hospital versus out of hospital patient characteristics. We can imagine the in-hospital patients were sicker, but then perhaps if you combine that with the time to ROSC, as you see lower in the subgroup analysis, it was also significant in the patients who had shorter downtime, less time to ROSC. So to me, this suggested it's possible just shorter downtimes are those the patients that may benefit the most from therapeutic hypothermia, and you get your most bang for your buck in the patients who are only down for relatively short periods of time, and then you could potentially give that neuroprotective effect of therapeutic hypothermia, and maybe those are the patients doing better, and maybe the in-hospital cardiac arrest patients who hospital survival is usually dismal. Just there was a study that came out from my institution in 2012 in the Canadian Journal of Cardiology that showed in-hospital arrest out of 84, only 2 survived to discharge. We didn't really talk about neurological status, but just 2 out of 84 survived out of that cohort. And so I know the numbers are much lower for in-hospital cardiac, are very low for in-hospital cardiac arrest elsewhere as well. So I just like to throw that at the audience. Is this just an effect of short ROSC, short time to ROSC? What are the thoughts out there?
Michael, it's Gurmeet. Not being a cardiologist, I am the least qualified person to comment. But I think that the common sense thing would indicate to us that the length of time to ROSC is probably the most important thing. Having said that, I think every one of us has the experience of having done 90 minutes of CPR and having CPC1 outcomes, right? So yeah, it's unclear to me from this how to interpret that, except I think I would tend to favor your analysis. The other thing I just wanted to ask, actually, everybody's thoughts on is CPC is a pretty gross global scale. There are much better neurologic functional scales that we can use, right, to determine outcomes. CPC2 means moderate, right? That means moderate neurologic injury. So I mean, if you're a pianist and you can't play the piano anymore, and we call that CPC 1 or 2, is that an acceptable quality of life for our patients?
Don't be shy, anyone out there. I don't know if we have any neurologists here, but I had that exact same thought. I was a little bit concerned whenever you see CPC2, which is, CPC 1 or 2 as a favorable neurologic outcome, has been the standard of outcome measures for these hypothermia trials, and that's been accepted as a standard outcome, a positive outcome. I agree with you. I'm not quite so sure that that's a great outcome.
But I think what the point of the CPC is that a 1 or 2, you have at least some degree of functional capability and can go home. You may need assistive devices, you may not be yourself, but at least you have some level of independent function. And there's some gray areas probably into what people would consider a reasonable outcome, but I think most people would agree that anything more than a 2 is unreasonable, and there's a lot of gray areas for 2s. And so I think a CPC for cardiologists who are non-neurologists is easy to understand, as opposed to some of the more sophisticated, you know, the neurologists use much more complex tools, which you know, us cardiologists, I think, like simple tools that only have 5 levels. And just my only other comment, just to get back to the question that was asked, was I find it interesting that the time to ROSC, that hypothermia was more effective in people who had less time to ROSC. The argument always in the past has been the opposite, that people with unshockable rhythms and longer downtime would be the ones who benefited because they had more significant ischemic time and brain injury and swelling. And so I find it interesting that this is counter to the previous theory that longer downtime meant, you know, that in the TTM trials, people said, well, in TTM, they said, well, 33 believers felt that, you know, maybe the trial didn't capture enough people with long downtime, and therefore the 33 didn't seem to work. And so there's always been this theory that people with non-shockable rhythms or longer downtime would do better with hypothermia, and this seems to be counter to that.
Craig, it's Gurmeet. Can I ask you a question? So when I read this trial, and maybe I'm not interpreting this correctly, but are you able to distinguish that the shorter ROSC time isn't actually the protective effect in these patients as opposed to the hypothermia?
Well, I don't think you can, because it's the only difference between the two groups is whether they received hypothermia or not. The randomization should take care of all the other confounders.
I just want to mention on Dr. Singh's comment, I think there's actually a consensus published showing that perhaps the outcomes should start becoming reported in terms of the modified ranking scale.
Yes.
And the guidelines also support actually reporting quality of life. I think the primary outcome for randomized controlled trials in out-of-hospital cardiac arrest has been shifting. A while back, CPC 1 to 3 was considered a good neurological outcome. Now it's only 1 to 2. I think maybe the authors are pressed to basically report CPC because these trials will be compared to previous trials, which also reported CPC. But I think moving forward, most of them should report the modified ranking scale. I'll tell you, on observational studies, it's surprising how many times you can find that the outcome does not differ if you use CPC versus modified ranking scale. And I think part of it relates to physical disability. I think I work with Dr. Lemaine. He's also doing a therapeutic hypothermia trial that finished enrolling and is probably going to report outcomes soon at the same time as TTM2. I wanted to ask the primary author, which I guess is not here, what he felt the difference was between Hyperion and maybe TTM. I wonder if it's actually we talk about non-shockable rhythms versus shockable rhythms. Is it the patient population that makes this trial positive, or is it because it actually included in-hospital cardiac arrest, in which case you can imagine that the cause of the cardiac arrest is reversible potentially, as opposed to patients who arrest in the community, or whether it could be a temperature issue. I know that 37 compared to 36 in TTM is just a degree, but there was that publication in Australia that showed that after the publication of TTM, outcomes started worsening because people became lax in terms of the practice of target temperature management. So I was just wondering what people felt. We were still pretty stringent in my institution because of the trial, but I know in other centers, the TTM trial, which was technically a negative superiority trial, not a non-inferiority trial, just led people to basically say that they no longer need to practice therapeutic hypothermia, which is concerning.
That's a great point. I actually just put on a slide comparing Hyperion versus target temperature management, and I'm a bit of a believer in this, not necessarily the depth of cooling, but the prevention of fever and free radical generation through fever. I know this is all hypothesis generating, but we don't know the exact mechanism of the neuroprotective effects of cooling. But it's interesting to see here between both the Hyperion trial and the target temperature management trial. And in the TTM trial, they actually were able to prevent fever to a higher degree than in the Hyperion trial. So I don't know if that may have also affected the results here. It brought up the fact that the normothermia group here did actually have fevers throughout the intervention period. So I don't know if anybody had any other thoughts on that.
I guess I'm just curious to know what are people's practices here. I mean, this has been published for 6 months. Has this changed your approach to differentiate non-shockable versus shockable? Or I don't know, I'm just curious to know what's everyone doing in other centers.
I would like to know as well, because this doesn't necessarily pertain to when I have my general ICU hat on. I would look after these patients, but the majority of these patients are deferred to ICU and don't come to CCU. Our unit takes shockable rhythms and non-shockable that are clearly cardiac, but the non-shockables go to the general ICU. So we wouldn't see in our CCU population, we wouldn't necessarily see many of these patients.
In our center, we still use the Zoll to cool people, which is we find a pretty effective measure. Even within the Zoll that provides almost complete control of the patient's temperature, we tend to aim for 35 at least, so that if we're actually off some of the time, we actually remain within the 36 degrees Celsius. I know a similar concept was published in the Canadian guidelines. They chose 33 versus 32, I guess, which was the American guidelines. And I guess the argument there, as I understand, was that 33 would allow them to at least remain above 32 most of the time and not necessarily go below it. But that's what we do. We chosen 35. Although if I was young, I would probably want 33. If I have an arrest, put me at 33 for now.
Hi guys, I don't know everyone here. My name is Brian Gladys and I'm a neurosurgical anesthesiologist. I did my fellowship at Massachusetts General Hospital and I did 6 months at the University of Pennsylvania in neurocritical care. So I can, and this is last year, so I can tell you maybe a little bit about what they do there and how they interpreted the most recent data in this area. This may come as no surprise, but they sort of treat everyone like highly aggressively, and they cool pretty much any cardiac arrest that comes their way to 33 degrees, at least for 24 hours. Some folks tend to sort of diverge at the 24-hour mark and lighten up their cooling to 36 degrees. Of course, echoing what was said before about fiercely guarding against hyperthermia. But so in that sense, their practice didn't really change in light of this paper, but I think that it's the way that they interpreted the in-hospital versus out-of-hospital story was not so much early ROSC, although that probably plays an important role, but that you start to get ideal care from the moment you're seen. There isn't a significant lag in the administration of kind of routine or guideline-driven care. You're moved to the intensive care a lot earlier. You have differentiation of your underlying cause and perhaps treatment of a reversible underlying cause earlier, and initiation of cooling earlier. And that's kind of how they interpreted it, being that we were never able to distinguish whether they actually achieved a controlled temperature earlier because they're lumped together in the temperature analysis. So, I mean, maybe that's not a very useful statement, but also they didn't change their management, but they did sort of interpret it to probably mean that you get more ideal care if you're identified to be in an arrest in hospital rather than perhaps an underlying cause or even early ROSC.
Brian, and welcome to CanCare. I hope we have you at other sessions that don't only have to do with neuroprognostication and things like that. But it just shows how important it is to have an interdisciplinary group of people here just to make comments. But one of the things that I just wanted to bring up in the study was that they looked at 90-day outcomes. But if you look at ICU survival and hospital survival and all those other, they were pretty much equal between the two groups. I don't know if future studies really need to. It seems like if they survive the hospital discharge with a good neurological prognosis, that's probably a a good time just to take account of their neurological status. We don't have to, give them 3 months or a year or 5 years down the line to see how they're doing neurologically.
Can I just ask a question of Brian based on our conversation before? I'm just revisiting the modified Rankin, and I'm wondering how it's significantly better than CPC, given what I'm reading here and what's being used in Pittsburgh.
So, I mean, it depends on the investigator largely. I think in terms of, they actually have a follow-up clinic, at least at the neurocritical care units in the Harvard Hospital, so Brigham and Women's and Mass General, and they tend to report in their system in CPC, but in terms of literature, there is a trend, you're right, towards MRS. So, I mean, does it make a difference? I don't know. The general feeling, and I agree, I don't actually understand why fully, but the general feeling is that MRS is more patient-centered, and I'm not quite certain when you actually, like you say, read the descriptions of each score, how that's true. And someone else was mentioning before that there are sort of more sophisticated patient-reported outcome measures, and there certainly are. But no, I don't have a good answer for you. And even on the studies that I was aware of being undertaken currently at both MGH and Penn, they had some that reported CPC and some that reported MRS. So. I don't know. No clear answer, sorry.
I just wanted to add a point about just the duration of the downtime and what Craig was saying, like what's the cause of that discrepancy. In the earliest of out-of-hospital cardiac arrest trials that showed a benefit of therapeutic hypothermia, at least in one of the trials, they mandated the use of epinephrine to maintain blood pressure or MAP above 90 millimeters of mercury. I always wonder whether suppression of cardiac output during therapeutic hypothermia, not necessarily by reduction of stroke volume, but by lowering the heart rate, could potentially lead to cerebral hyperperfusion during the immediate post-cardiac arrest state. So, if I were to interpret, and this is purely speculation, we always see patients that have a myocardial dysfunction after out-of-hospital cardiac arrest, a lot of times simply because of whole body ischemia, even in patients that are non-cardiac causes. And you would think that people who are arrested for longer would have a greater degree of myocardial dysfunction. And therefore, if you don't correct that and ensure that the cardiac output is basically somewhat more normalized, providing therapeutic hypothermia at a lower temperature target could potentially diminish that even more and compromise cerebral perfusion. I'm not sure if, what other people think. I think there's always a belief that if you decrease the patient's temperature by, 3 degrees, you don't need cardiac output. But in all these patients that may be septic, that just basically overcame a major insult to the body, that may need to be corrected. So the question is, could there be an interaction effect between therapeutic hypothermia and just the patient's cardiac index? I'm also trying to conduct research in that, so if anyone here is interested, please contact me. I'm trying to organize a randomized control trial, but just something to throw out there.
Could have an RCT that was helped organized by CanCare Virtual Journal Club, and so please include in the acknowledgement section of your paper at the New England Journal that the match was made at the New England CanCare VJC. We have just a couple more minutes before we go. I just wanted to know, has this study changed anyone's practice? We mentioned what's the current practice. Is anyone going to practice any differently from this study, or are we all going to kind of hedge our bets? Like I can tell you, a couple of other people mentioned, because I tell the nurses to kind of aim for like a moderate target, like temperature of 34. So if they overshoot by 1 or 2 degrees, that's fine. If they undershoot by 1 or 2 degrees, that's fine. So they don't go to 31 and they don't go to 38. That's been kind of my strategy in most of the patients, especially when you use external cooling. It's a little bit harder to be specific. So I just want to know anyone else's thoughts on that.
We've been at 35 for probably 5 years now across the city, and that's just because the ICUs were using, non-feedback based cooling blankets that were not very sophisticated, and they felt if we went to 36, there'd be too much up and down and potential for fever. So I haven't changed my practice because we're at 35, and I'm not convinced based on this trial that you know, that 33 is better for this group.
I think this trial is probably more relevant for in-hospital cardiac arrest than out of hospital cardiac arrest. I think in many centers, people didn't necessarily routinely cool patients with in-hospital cardiac arrest. So this is kind of evidence to support that practice. We should be considering that more strongly. I don't know what everyone did. Before this, the discussions were had, should we even cool in-hospital cardiac arrest patients? So this is evidence that we probably should.
Kind of take away the same thought. Wrap it up unless anyone has anything pressing to say. Thank you everyone who participated and Mia for presenting. I think that was a very interesting paper. It may not have actually changed our practice except for potentially in hospital cardiac arrest, but I think it's a lot of food for thought. We look forward to similar papers on the similar topic coming out soon that we could discuss right here in this format. So everyone be well and take care.
Thank you very much.
Thank you very much.